Everybody, welcome to the fourth of the series. Today, what we shall be focusing on the internet-based weapons or IT-based weapons, with a focus on Internet of Things (IoT). So, taking a cue again from my very first webinar on the subject, post COVID-19, we expected a new world order. A lot of people said that life would never be the same again globally, and I think they are right. This is what we are seeing. We're seeing a lot of transformational learnings that have happened. There's been a paradigm shift in the healthcare post COVID-19. So let me just quickly recap some of these key changes that we have seen, which is going to really impact the future of healthcare. In March 2020, the entire healthcare system, as we know, was challenged by the COVID-19. We saw a very quick authorization and adoption of telehealth. It was within a matter of a day that telehealth was authorized with guidelines coming in from the government. The FDA also jumped in and introduced emergency use authorization for any devices, ideas, innovations relating to the COVID-19 pandemic. Even the insurance companies started waiving certain requirements, as in the USA, Medicare, and allowed a lot of flexibility in the treatment part. HIPAA exemptions, that was very, very important. A lot of restrictions were there on telehealth and the way we practice telemedicine because of the restriction put on by HIPAA. And they allowed Skype, Zoom, WhatsApp, all these which were previously restricted. And both from the general population and from the doctor's point of view, a lot of focus went on preventive healthcare and wellness. So definitely, these are the things that we've already seen. So to come back to the topic today, the important concept of digital health is what we should understand. Digital health is the generic term that will take care of any kind of interaction between a healthcare system and the client, which in this case the patient. But the essence of what drives digital health is really the fact that it is patient-centered. And as they say, that you have your health in your hands, depicted very well in this illustration. Now, the evolution of digital health actually happened in three phases. You could say the 90s, then from 2000 to 2010, and of course, from 2010 to 2020, just divided roughly into 3 decades. E-health, T-health, M-health, respectively. So e-health was what a lot of us would practice with a very simple PC, a printer, and we had our notes typed electronically. We had prescriptions also we could type out, take the printout, give it to the patient, and to some extent, fair amount of records, particularly discharge summary, medical legal records, were being maintained by hospitals and by institutions in healthcare. Quite successful. Then came the next decade where teleradiology started a revolution. From teleradiology, we had teleconsultation, telemedicine, and of course, telehealth. The distinction between telemedicine and telehealth is quite ambiguous. It's often used interchangeably. But just as far as the WHO is concerned, telemedicine is by doctor-patient interactions, and telehealth is any healthcare worker, not necessarily a doctor, interacting with the patient. Now comes a very exciting decade where many devices that came, which allowed us to remotely monitor certain important parameters. Also, there were wearable devices that you could put on your wrist and put in other parts of the body, which would constantly give out data that doctor would need in better management of the cases. Then came, of course, the Internet of Things. I don't want to get into the basic concept of Internet of Things, but fundamentally that when machines start talking to each other without any intervention of any person, it's basically Internet of Things. So it speeds up, introduces efficiency of processes. So Internet of Things is a huge revolution that is now coming to the healthcare industry. And I think we're going to see more and more of such devices. One particular device today, very, very interesting device, will be presented by the inventor. Then, of course, there is the concept of machine learning, artificial intelligence, which would make this a much more realistic, the experience. And finally, we would probably, all of us would get into a virtual reality-like situation where we would actually physically feel that you'll feel that you're in the doctor's chamber talking to the doctor in 3 dimension, maybe holograms or anything that will be introduced, and that would come very much in the future. But we are not very far from this in terms of concept, and these have already been established. It's not really been applied in healthcare, or for that matter, even in other industries as of now. So from here, what has really changed is, of course, initially it was the PC, then it was the internet revolution, and then it is the mobile phones. And that's why we had 3 decades of evolution of digital health, starting from e-health to t-health to m-health. So in 2016, a study that was done by TMR agency that does analytics for the market analysis, etc., they predicted that from 179.6 billion US dollars in 2006, this market would grow to about 536 billion by 2025. And of course, there came this punctuated equilibrium by Corona, and there was there were disruptive changes, and it is very easy to imagine that probably it will be a lot more than $536 billion. But time will tell where we are. But the whole idea is that this is where, and this is how healthcare is really going to progress. As they say that if you follow the money, you will be able to get a lot of the history. But here, if you follow the direction of the growth, you will also be able to tell the future. There we go. Now, just for understanding, I'm going to explain 3 basic concepts so that people don't get confused between teleconsultation, telehealth, and telemedicine. So most of the practice today that we have seen during the COVID-19 lockdown and post-lockdown is that now the patient interacts with the doctor by phone, email, WhatsApp, any other method. The doctor looks at the symptoms, decides that the patient needs some treatment. Meanwhile, perhaps the patient has some lab reports, radiology reports to share with the doctor. Doctor gives the treatment with a few disclaimers, and the patient takes the treatment, goes to the drugstore, get the medicine, and there's a payment gateway that connects these so that the entire loop is completed. Very simple. And almost every doctor is now on there's so many platforms that provide this teleconsultation model. Of course, the next level is a telemedicine model. The telemedicine model is slightly more complex, where there is an interaction between the doctor with the radiology and the labs. There is some more interaction between the doctor and an institute, a group of doctors practicing, and the drugs through various online portals can be sent to the patient. So a little bit more advanced. Again, payment gateway connecting these is how the telemedicine really works. Again, there are many portals that provide this, but this is not the future. This should have been evolved many years ago, and now we come to a much more complex model that I myself was or am involved in, the Bellesante model, where we have blocks. Now take this block here, the GP, the specialist, the home care, and the hospital. This block is interacting with the patient. A lot of data here exchange happens over here. The patient, these GPs order some tests, again data exchange happening here. Patient, labs, data exchange happening over here. And now with all these blocks, there's another block over here. And this block, the difference is that this block is no longer an institute, no longer a doctor, no longer a single building. You could have a virtual hospital, and the doctors and the participants can be from even, from all parts of the country, or even for the world for that matter. And they will be supported by a very strong electronic health record. That is the heart of any such process, that data has to be analyzed and put in such a way that it is very easy to retrieve, very easy to understand, and in a manner in which is acceptable by the regulatory bodies. Therefore, it involves a lot of training, a lot of admin costs come here, a lot of admin efforts come here. So it is intense in terms of manpower, intense in terms of effort also, time also, and to some extent it's expensive. But it's how we work and how it's happening. And then there is the interactions between the drugstores, logistics for shipping medicines, etc. And this is how it's sort of more or less complete. And we use a platform called the M-Notes, which has been again with us from 2009 onwards, or actually 2013. Between 2009 and 13, it was being developed on another platform. And there we go. So with this, if you look, it looks very complex, looks very complicated. And how are we going to put all this together? Right now, we are doing it, and some of the members who are today attending this webinar are part of this entire matrix we are here over here. So how do we make this matrix simpler, quicker, and efficient is the next step. So that's where the Internet of Things come in. So Internet of Things will evolve from Internet of Persons. So right now we are in IOP, the Internet of People rather. That is teleconsultation, telemedicine, telehealth. All people driven. Now if we integrate this with the remote monitoring devices, if we have remote monitoring devices, and there's one device again today, the inventor or the very inventor of this device is going to be with us and talk about that one device. Healthcare today, if it's going to really progress and move very fast, it will go through IoT. There's no doubt about it. Once it goes through this phase of IoT, and IoTs are sort of connected, I would say there are thousands, lakhs, or even millions of IoTs around. Every day people are thinking out of the box, creating solutions, apps that basically are in this IoT domain, not just for healthcare, but in general. So from the IoT, and once this IoT phase is through, we will get into something called as Internet of Everything. That means along with the IoT, there will be interaction with data, people, things, processes. So we started off with things, people's, processes, data. The only thing is they were all disjoint, each one working, and the processes were disjoint. Now the IoT, I believe very strongly, will bring all this together, and then once we combine this, we will have what is known as Internet of Everything. And it's a very simple word. Everything means everything. So now, just to give an example, in the COVID, just a simple example, that if you have had connected thermometers, this little girl with a device here under the armpit, which constantly is giving the temperature readings. So if you just take one parameter, the temperature, and have devices that can be linked to other devices that is collecting all this data, and then you see what Kinsa Health did. Take all these devices, and actually you could see a sort of a map around the entire USA, how people are moving, over 1 million connected thermometers, sort of using one parameter, a very simple, this parameter is called the fever scout, and connected thermometers, and applying this another device on the wrist. With that simple data, you could sort of predict where these fevers are going, what is the trend, is this, especially if you connect this fever to a virus, one parameter. Of course, we know that it's not as simple as that, but just for sake of explanation, I took this one parameter. It helped to search and find patient 0, and also perhaps monitor the high-risk patients, okay, in a very simplistic way. I try to put it just for sake of understanding. Now, we have our own apps also. It's part of IoT. Let's take the Arogya Setu app. Okay, it tells simple things like warns you when somebody nearby has been tested with COVID-19. It tells you what preventive tips you should take, connects with the essential health services, and of course today you can't fly if you don't have this app. So if you need to take a flight, you would need to have this app. Very simple way of taking care of social distancing and giving information to patients, warning which areas they should avoid. Simple tips. So very simple, very useful app. The other one is the Corona Kavach, and that says that you can check whether the user has crossed path with somebody who has tested positive. That's another one, and then you can take the precautions that you need to do. Ola has come out with these apps with emergency and healthcare support, logistics and vehicle movement, supply chain management, law enforcement. So these are very simple apps that we can see, use it, not very difficult to use. Now comes the very interesting app. I was very, very impressed by what he showed me, but I want him to share with all of us.
Thank you so much. Let me introduce Dr. Kannan. He is a pharmacist and biomedical scientist who has been working in the industry for a long time and is currently also passionate about being a health and patient advocate with Zion Hospitals and Research Center. Today he'll be talking about Lyfas, which is a product by Acculi Labs, and it is a fantastic mobile health monitoring and possibly diagnostic aid tool. And so without further ado, I'm going to pass it over to him.
Hello everyone, good evening. It's a pleasure to be part of this webinar. So Lyfas is a smartphone-based mobile application which was originally developed for the purpose of predicting cardiovascular, cardiorespiratory, and cerebrovascular events along with few indicative biochemical changes in blood. All of this we could do it by simply placing a fingertip on the smartphone camera and capturing the light signals, and then converting into using smart algorithms and mathematical model, which Mr. Rupamdas has developed painstakingly. The story of this invention is very interesting in the sense, with respect to COVID, is that as early as January, Rupam and the team realized that this pandemic is due to take off from the Chinese territory. So when we came across cases in thousands, he actually got some anecdotal evidences by making people who are COVID positive in China use this technology to give us some unique signatures, parameters out of this device. And then we started gathering anecdotal evidences for detecting COVID infection, using this device. The device essentially works on the principle of photoplethysmography, which is a long standing technology. The simplest device I can tell you for all of you is if you go to your hospitals and get admitted, you have the pulse oximeter, which is put on your finger. Lyfas has got an additional input signal apart from the pulse wave, pulse plethysmography, which is PPG. It has also captures the photochromatographic signal coming out of the device when placed behind a smartphone camera. So essentially, it has got two input signals, which is the blood volume changes coming out of the photoplethysmography, and also the spectrum, light spectrum, which is generated against the blood flowing underneath your finger. And so those spectrum generated has relation to various blood components. So this is how this innovation started. And very simply, the purpose of the innovation was to empower people with the knowledge and solutions so that they make informed decision making instead of unnecessary panicking. So we are in difficult times. Everything and anything is a news. Misinformation and conspiracies are always loaded upon the people. So in order to debunk all these problems, we came out with the solution so that people can record their health using the smartphone with the help of this application, which they can download. So essentially, it is a non-invasive remote monitoring device application, which is also has an advantage of self-administering. So you don't need any qualified health personnel to execute this test. So it is personalized on your smartphone camera, where the entire population is owning a smartphone camera. So we made use of this current situation to develop this. So the parameters which are gathered out of this technology gives out an early warning signal of somebody coming across viral contact or exposure. So therefore, it enables a faster means of public health measure deployment, resulting in patient isolation and contact tracing, which in turn by itself reduces the transmission. One of the biggest problem what we are facing globally today is, even though the infection is affecting 5% very critically, but there is also remaining 10 to 15% who are mild and moderate. But the challenge remains, there's 80% of the population who are called asymptomatic, or we even call it pre-symptomatic. So in spite of contracting the virus has got a long incubation period, anywhere between few days to weeks, up to 24 days. So in this particular period, these are people, 80% of the population, who are super carriers, and they can actually transmit the virus without their knowledge into the more vulnerable population, which has got coexisting diseases as well as elderly.
And I would like to bring in Dr. Nilima, who actually used your technology today for the first time. Her thoughts on, was it really easy to use and how she felt as a consumer.
Hello, everyone. I was really amazed that a person like me who's not very technologically savvy, though I'm a doctor, and having a smartphone which is not the Gen Next type of smartphone, a fairly old one, it's a very simple single camera and all that. I could download the app and run the test by just putting my finger on that camera according to the guiding voice that was there as part of that app. And in minutes, that report, it had analyzed so many parameters of my health and it came into my email box. It's pretty amazing. And I think it will really help remote diagnostics and monitoring for a lot of patients, not just COVID. Thank you.
This device which Dr. Kannan spoke about actually analyzes about 42 parameters or more with respect to the COVID. Of course, it has various algorithms for diabetes, hypertension, metabolic disorders, all that I've seen. So the beauty of this is that it basically looks at fundamentals, inflammation. It looks at immunity. It looks at the variations in your pulse rate, etc. So all the data, and of course the IOT, the back end, the brain behind, which is analyzing all this, and the doctor that interprets all this is equally important. But we can see that with what is known as machine learning, artificial intelligence, all that will be so quick that very soon, I would say this tool would be a very useful diagnostic tool. So let's see how it goes in the future. With the COVID, it has proved its role, and I think Dr. Kannan is now going to even talk to people globally about this. I'm just going to bring in a case study that was done at Frederick Memorial Hospital, Maryland, and they just created a remote patient monitoring telehealth platform. Not important what platform they created. I've been through the entire details of that. But the conclusion was quite destructive. One, that the ER visits decreased by 50%. It reduced hospitalization by 90%. And the cost of care was cut down by 50%. Now, that's how it's going to go. So if you imagine that even these inventions which are going to cut down the cost of diagnostics, it is going to be a great boon. More information, less cost. And that's exactly what it is. In fact, what these devices do and what the IoT does is it really cuts down the admin costs, which involves human interface. There's always a lot of admin costs that comes in. And just to give an example, I understand that insurance companies, they say that the admin cost for every dollar that is spent is as much as 90 cents. So that's quite high. So anyway, so data-driven platforms will enable providers to preemptively identify the health issue, as Dr. Kannan presented. So a remote monitoring device is all about taking existing device. So you cannot have a remote monitoring device that is absolutely new. You take an existing device, like in this case, you have blood pressure apparatus, you have something that measures the pulse oximetry, something that measures the weight. Now you reinvent it, and then you make this into a device that can be done remotely using the mobile phone as the media. That's the fundamental information. So patients here finally can take control of their health and they can make informed decisions. Probably the only downside to this is that you would have a lot of patients that will be over anxious. They may be hypochondriacs, and you have people constantly. I've known a lot of people that wear the Fitbits that are constantly looking at the Fitbit and sensitive to every change of the heart rate, etc. So I think we'll have to find out how to deal with that situation. But right now, we will focus on progressing and making the devices more and more useful to give the data. Yes, from here, the IoT will definitely take off.
Let me introduce Vibhav Joshi. He is a BITS Goa graduate and a very young founder of a startup company. And FetalLite is their product for labor monitoring. And I will let him tell you a little bit about the product itself and how specifically it has helped safer and more efficient deliveries during the time of COVID-19.
So first of all, thank you for having me. It's a pleasure to be here. The product we have developed is fundamentally a fetal monitor that's used to measure the baby's heart rate and the mom's uterine contractions. And the logic being that when the contractions start, or as the gestation, the amount of time post, or rather towards labor progresses, there are certain factors which can affect the baby. So either it's the stress that's being put on the baby, or its shoulder might get stuck, or multiple factors because of which it's at risk especially post 36 weeks and during the time of labor. The standard technique to monitor these babies and to determine if any such distress condition is happening is by measuring the fetal heart rate, because the fetal heart rate trend drops. So if the baby is in distress, the fetal heart rate is, let's say, averaging at 140, it tends to drop to, let's say, 80 or 60, and that pattern keeps repeating. So that's a leading sign that the baby is in distress or might have some issue. And then the doctor can choose to do a C-section, can give some medication, or ask the mom to eat or walk about so that the blood circulation increases and the baby gets more oxygen. So that's the problem that we're trying to solve. Now, conventional devices which are used to monitor this condition are very bulky devices. They weigh 5 to 9 kgs. They can't be carried about. They're not portable. They need a lot of infrastructure in terms of having a power point, like a plug. Also, they are very skill dependent. So you need a very, very skilled nurse or a doctor actually to operate the device, because obviously the mom is moving, the baby moves. So it's all, the position of the heart is not always in the same place with respect to the abdomen. So you have to keep moving the probe. You have to localize where that probe has to go. If the probe slips, there's gaps in the data. So the analysis of the data becomes subjective. So it's not a very user-friendly kind of procedure with the conventional devices. So we decided to solve that by building a very small probe, which, if you can see in this picture, basically just goes and sits on the abdomen, on the navel. It's centered on the navel. So the advantage of that is, A, you don't have to localize. You don't have to do any kind of skin preparation. It sticks to the abdomen, so it does not get dislodged with maternal movement or fetal movement. And therefore, it's a plug-and-play system. So even a very low-skill nurse with 1 or 2 demonstrations is able to do this procedure. Also, we have built algorithms which improve the quality of the output significantly. So we have much lesser gaps in the data. We have a much higher confidence on the fetal heart rate. In the conventional monitors, you used to get a phenomenon called fetal maternal confusion, in which the mom's heart rate sometimes used to be captured as double and shown as fetal heart rate, and the fetal heart rate was missed completely. So some of those sort of gaps in the conventional devices we have solved. Now, the advantage of this, specifically during the COVID scenario, is that mothers and babies are vulnerable populations. They already have a higher chance of catching certain viruses or diseases, and the idea is to try and minimize the number of interactions with the hospital environment. So we want to limit the number of times the mom has to come to the hospital. It's not just us, even ICMR has published guidelines now which asking the doctors in the public healthcare system to try and limit interactions, to introduce telehealth solutions or telemedicine solutions to limit number of visits. And that's where we come into play, because our system is also an extremely portable system, and it was designed from day one to be a internet connected system. So fundamentally, all the analysis happens on a tablet. That tablet is also connected to the internet. So all that data is pushed to the cloud. A lot of the analytics can be done on the cloud. The cloud can also send update reports to the doctor's phone. So the doctor also has an app. So we are trying to partner with healthcare at home providers such as Portia and Nightingale, who will take these units now to moms' houses. Either the nurse visit or the mother also can be trained very easily to perform the scan, and the scan directly goes to a doctor. The doctor can then guide the mother on the next actions. And we have done about 5 such scans now, and we're hoping to really scale it up starting next month.
Okay, that's great. Thanks so much, Vibhav, for this great product. And I think it's an example showing that when you design to solve a real need and a problem, the flexibility in times of crisis are even more. So I'm handing it back over to you, Dr. Kadambi, to sort of conclude the session and get to the Q&A portion.
So, yeah, thanks, Vibhav, and thanks, Pooja. Now, I just want to share something over here. Because I've been associated with innovators, we've been associated with inventions, and typically when we would meet, we always had this problem with the ultimate user, or rather the doctors. They would ask, why would we do that? Why would we like to have this device when I would rather have the person coming to my clinic? I can do this, have a fancy ultrasound and do all this monitoring. And they had this fear. There was this sort of a paranoia fear which was actually unfounded. They would probably not come to my clinic. I don't know, that insecurity was there. They probably go somewhere else, or they would sit at home and get the treatment. They would be treated by quacks, and everything would sort of talk around that. Now, thanks to the COVID, and I'm using the word thanks consciously. Thanks to the COVID-19, a lot of these inventions that were not looked at or were not really facilitated innovations, they are now going to come into limelight and occupy center stage, and it will force the doctors to make the changes and change in mindset. Keep this in mind as our series progresses. Probably I'll be able to give more and more evidence of what I'm saying. Now, just to summarize wearable devices, there are so many wearable devices, but fundamentally with these wearable devices, you can get your heart rate, your ECG, your blood pressure, your quality of sleep, breath rate, emotions, whether you're fatigued, how many steps you've taken that day, how many calories you've eaten, a panic button, etc. So yes, now it's all there. Now, only question is, how do we use this data in order to make the life better, or in order to make our treatment better, or even in preventive treatment and wellness. And this we have already seen, and we are already using this in our practice too already. Very interesting was one particular data I wanted to share with you is a contact lens. This contact lens, if you apply on the eye, okay, I don't really know whether it will be really successful or it will be accepted, but it can measure your glucose level in the tears, from which you have an idea about diabetics, the level of glucose, with some kind of correlation between blood glucose and tear glucose. You should be able to tell whether a person is going into hypoglycemia or sugars are going high. So monitoring of blood sugars can happen with a device that you wear like this as a contact lens, that small fine lens here. And of course, not necessarily that everything has to be high tech. A simple device for senior citizen or senior citizen villages, like where I stay, is that you can tell about the movement. If somebody has had a fall, a simple, very simple device, or is incapacitated, we have sensors on their body that will sense it, and the corrective actions can be taken based on the triage or based on the contingency plan that you have planned. In general, it's going to create better habits, reduce the strain on the healthcare providers, reduce the insurance premium, and save lives. Now, the only thing that this often comes up is, what about that human touch? What about the touch, the doctors, compassion that comes through the touch? And you can't get this obviously when you have a robotic or a device that is doing it. So yes, so I do understand that there will be a touch, but it need not be. It's not necessary that me as a doctor has to have that touch. There could be actual the home healthcare service who have been trained, designed for for delivering the compassion, the human touch, and they will have to be integrated. And therefore, from the IoT, from the Internet of People, IoT, it will have to finally come to the Internet of Everything. So we will have to definitely look into the aspect at some point of time when these IoTs become very common and day-to-day use, that how do we ensure that the human touch is also maintained. I can't imagine how the situation is, but when that situation happens, I suppose that we will be looking at introducing that also. We may have specialists that are, well, I don't know, touch specialists or empathy specialists who would actually do that interaction with the patient, and they will be also linked to the system. This is my sort of a prediction, but I don't really know how that will happen. Or we will have to sacrifice, and we have to decide that, okay, the personal touch is not possible, or it will be only safe for those who are willing to pay a premium for that kind of service. So after the integration is over, let's now take the questions. Thank you very much.
We can start the discussion with Dr. Ashok Kadambi's question, which was very valid and around data security. So I'm going to get our other guests concerns around patient privacy, and now you have location data and how it can be misused, and the implications of IoT and healthcare in terms of help. To put it in his terms, actually helping things become more of a surveillance, lack of privacy space. So Vibhav and Dr. Kannan, you're both unmuted. So would you like to start off, Vibhav, with any points?
Yeah, so specific to the FetalLite, the model works where the healthcare data, the patient's data, the ownership is with the patient, and any analysis that happens, the ownership of that is with the doctor. So we are just a layer that's providing the instrument for the test, but the data rests with the hospital server. So we don't have any access to it. Neither does any third party. It's not as if the government could take the data directly from me. It would have to go to the hospital with the normal channels.
So you're
so
not.
That way,
you're not running it on like an Android platform or something where like it can get
That's
hacked through a
local
phone.
on the device.
Okay.
No. So while the test is happening, it's local. The data, patient data gets transferred to the hospital's cloud, hospital server. So I don't have access to it.
Yeah,
I get
actually, the
anonymized.
question that Ashok really is saying is not about the pregnancy device. We're concerned in
Oh.
general about this information and IoT. Let's get out of that. And if Dr. Kannan
Yeah,
has
because
something to
there is a
add,
mobile device that has location and monitoring
no,
and sensor, right?
I mean,
Dr.
you
Ashok's
can
question.
follow certain global guidelines to build data security in.
Correct.
To
So
the extent,
let me ask Kannan if he has something to say, and then I definitely have something to say. Probably my views will be very strong. So
Okay, so
let me allow
We
Kannan to say
were,
first.
do you have any?
to answer your question, from the day one, Rupam was very conscious about this, about the data security and the personalization of the data to patient and the care provider, which is a doctor. So within our Lyfas application itself, we have made provision for a patient version and a clinician's version. And the output, the report which comes out of it, it's got a patient version of the report as well as the physician version of the report. And the beauty of Lyfas is it can be operated offline, right?
All right.
And then later connected.
And I think we're going to talk general.
Yeah.
I'm going to put it very clear. I think this data security is a myth. So let's face it. Okay, either you get off the grid, you switch off your cell phones, you shut off, and you live in an island or wherever, or you live in where we are, where the data is being exchanged right, left, center, whatever you say. And if you see, the HIPAA compliance actually was relaxed because the fact was that was coming in the way of treatment. All these regulations, whether coming in the way of treatment, will have to be relaxed. I cannot think of a situation where you have a foolproof system. Even in the old system, in my hospital where there's a file, my chaprasi can take the file and read the name of the patient, or read whatever. So the data security is a myth. The only question is, what if people hack? What if people take the data, misuse it? That's where the laws have to come in. That's where those people have to be discouraged from doing it. But can you say that I'm going to stop crime if people are going to steal data? People are going to do things that are illegal. Yes, there has to be someone looking into that. But to put the onus on the doctor, to put the onus on the device that we should do this, at the most you can say is encrypted and from one end to other. But as such, the government knows where you are. The Setu app, the Arogya Setu app, it will tell exactly how you are moving. So your entire privacy is coming into that. So it is actually going to lead to illicit spying on the citizens, as Dr. Ashok says.
Yeah.
The question is, we have to start getting used to it. And I'd like say, okay, bring them on, take my data, whatever you want, do with it. I'm going to live my life. I'm going to do as it is.
Then one of the other interesting questions, which is about how do doctors, or how with this remote telehealth and all, how is it monetized? Like how can insurance reimbursement happen? How does the doctor or caregiver get compensated? We can use specific examples. So Vibhav, if you want to discuss how the payment model would work with or the FetalLite, the scans, how it enables the payment model, please go ahead, and then I'll get to Dr. Kannan and then Dr. Kadambi.
Sure. So today, let's say the patient has to come to a hospital. The average charge would be between 500 rupees to 1500 rupees, depending on the kind of hospital they're going to. And I think we are pricing it now at 1000 rupees to the patient. We take some 200 rupees out of that. The operational partner, which is doing the going to the patient's home, takes 200 to 300, which again fits into what Portia is charging for certain of their home healthcare services. And then the doctor or the hospital makes the same kind of money that they make at a lower end. But what the patient is paying extra for in this case is not having to go to the hospital. So the the protection they get, also convenience. So I think in that sense, nobody has had any issues with the pricing model we have.
But the device itself doesn't do some sort of pricing or payment portal or anything. That is still between the doctor and
we have built it to be modular so that depending on the operational, how it operates, we can give different payment gateways.
Okay.
So they can pay on the device, they can pay for consumable, or they can it can be plugged into the labor monitoring charges as a package that they pay to the hospital. And then we can decide how to split the revenue.
Right. Okay, same thing. So, Dr. Kannan, your product, in fact, it's so consumer driven and it's with the consumer, right? For them to do self monitoring and things like that. How are you able to, monetize or charge for the diagnostics or the testing? Or can you explain a little bit of how that works for the
Yeah,
product?
I think it's very simple. So we have two models. One is a need-based subscription. It's need-based. So as and when you require this device to be used, you can download the app and then pay a subscription fee for that period of time, whether it's a day or a week or a month or whatever it is. The other option is we have an annual subscription mode, which both doctors as well as patients can use it. Now, with respect to physicians, they can subscribe this application again on a need base and have a revenue sharing model for the innovator as well as the physician. The physician's role is very much here. It is not completely off. So therefore, the interpretation of the results which the patient shares with the physician will have to be monetized. So therefore,
but the physician doesn't bill for your app. Like this app is on the patient side and they pay for the subscription, correct?
Correct.
Okay.
So the patient pays for it.
Yeah. So that's great. So thank you. Dr. Kadambi, I'm going to unmute you. If you want to discuss in terms of from a telehealth standpoint, have you taken advantage of payment portals and things like that to enable payment? Have you had any issues with patients feeling that if it's not an in-person visit, it should be less, not more? Over to you.
Yeah, so this is going to be the next problem which I've seen. Luckily, I have been through this for many years, but today doctors are experiencing for the first time and they feel very odd and clumsy about it, because when a patient enters your clinic, before they go out, the money is collected out there. So they know that they don't have a way out. But now with all these WhatsApp and this, I literally, I would say that what have I experienced in the last 5 years is now almost being bombarded by messages. I tell you typical messages. So let's put it this way. Patients in general want to pay less and get more. Doctors want to do less and get more, whichever way. Let's take a human one. You want to be paid for your service. The patient also wants to be paid for it. But it is subjective, what I do. So if I visit now, I just visited you 15 days ago. So there are various ways in way in which people monetize, saying that every 15 days will not bill. But the problem here is different. You see, the mindset has to change from both sides, and it has to be very clear cut. So if the patient has direct access to the doctor, okay, if through the WhatsApp, whatever, it's going to be life is hell for the doctor. So like in your clinic where you have a secretary who will take it, all the things will be routed by a different portal that will take your appointments, and this is already being done. But I know patients that ask, can I talk to the doctor? They say, sure, give an appointment. No, I don't want an appointment. I want to talk to the doctor. So do you like a consultation? No, I don't want a consultation. I want a discussion. So I've seen all these things where they will use different words and not use the word consultation. That's one. Second is, as Ashok has often said, when the insurance comes in, there's a bigger issue. Insurance will decide. They have to decide how many visits are allowed for this condition. So here's what's going to happen is it's going to be a big mess. But from that point of view, let's accept it. That's a reality. So my telehealth platform will actually go by the international SOAP notes, ICD codings, the lab tests related to the coding. So you should have a very, very good EMR. That's why I said having a electronic, for any doctors who are listening in over here, the key is to have a good electronic documentation platform where, and if an insurance were to look at it, they cannot deny the payment. And there's no point in complaining that insurance people, they're vultures, they will speak us, they will not do anything. So just create your things which is compliant with them. But that's going to evolve. You have to learn how to do it.
Thank you. I'm just going to hand over to Dr. Ashok, since as a practicing endocrinologist in the US recently who came back from the COVID-19 filled city of New York, where he volunteered to help. In your practice as an endocrinologist, and since you deal with a lot of lifestyle related diseases and disorders, can you comment a little bit on how wearable devices or IoT is helping your practice and where you see it going in the future to better benefit?
Okay, my experience with this IoT things and all that, Vivek, is that we never get paid. We never get paid because the insurance company says, no, unless there's a face-to-face encounter, we won't pay you. Then they say, okay, you can bill a telemedicine code for that. So when we do the telemedicine code, this is not reimbursable. Okay. So as per contract, we don't get paid. We only get paid on a face-to-face basis. So I think this model does not work.
So, I mean,
for
but is it, but do you
It's
feel
not
that
working. Let me put it
technology, does the technology have benefit and it's the payment portal that's making it unworkable, or do you feel the
Yes,
technology itself is?
I love the technology. I love to use it, but I cannot do it for free.
Okay, so you need a systemic level change before you can actually.
I need a level change where actually the doctor is included in the loop. When the machine is sold or whatever the subscription model you guys have, give us a part of that.
Okay. Okay.
And it should be doctor driven. In other words, the patient shouldn't just buy it and say, now analyze my data. No, you have to pay. Every patient that buys the device should be assigned a physician, and that physician should be in the reimbursement loop of what you collect for the device.
Okay.
That's the only way it's going to work.
That sounds like a very interesting model. There's another point that was brought up by Mr. Gururaj about how everything is focusing on infection control today, but geriatric care, and now they are also a vulnerable population with COVID. So if any of our speakers, you can just raise your hand and I'll unmute you. You can take the question about how you see IoT wearables actually helping improve care of vulnerable populations, specifically geriatrics.
Both Dr. Nilima and I, we are very much involved hands-on in geriatric care on a day-to-day basis, because as many of you know, we actually chose to live in a retirement village, which is quite a paradox, because my father, who's 90, and my mother, who's almost 80, they're living in the city as young people, and me and my wife in our 50s, we are staying in the retirement village. But anyway, the reason was, here the point is different. The care of geriatric care through IoT, I think that it's only a question of understanding that that you should trust the technology. I think with the geriatric population, the first thing that happens, it's not a question of whether they're tech savvy or not. I've known, I can see Ashok Day over here. He is even, despite, I won't even talk about his age, but I would say that his mind is sharper than any of the young people that I know. So adapting is not there. The question is that they should understand the value for that, and they will need to know the immediate value. You can't tell them that in 20 years from now this is what happens. So one is to make sure that monitoring those devices, as you saw, that is for people who are afraid that if something happens to me, what do I do? And that technology is very easy. The other thing is these parameters that are being taken, as you say, IoT, that's going to be extremely useful. But to get them to buy in is going to be an effort. You cannot patronize, especially senior citizens. You have to explain to them, and the buy-in comes. And the third thing is, we are all used to getting things for free. So the first thing is that how do you create a model like Hotmail created once? You can give something for free, but have some kind of subscription charge. So if you are able to address these few, or if you are able to convince a geriatric population that you have to pay for the service, that is another the challenge, that for every service, and you may not know when you need it. So if a person has that mind block that if I need it, then I'll pay, then it's not going to work. So that is definitely a very, very important aspect that will come in adaptation of IoT. But I'll put it this way: first, let it work with the young people. If the young people accept it, and I can tell you, if a person sees his grandchild or her grandchild, playing with that grandchild will teach the grandparents how to use it. I can tell you today it is the grandchild. So you work with the grandchildren on the children or the grandchildren, and you will be able to get the acceptance. This is my view.
Yeah, I think that's a good point. Specifically, there was a question earlier for Dr. Kannan. Dr. Kannan, in the technology, because there is a user is using a phone, and there's variability both in terms of users and skin types and all of those things. How challenging was it to establish accuracy and as they say, sensitivity, specificity, and how are you dealing with challenges of that, the accuracy factor, when you have such a diverse user base?
Well, thank you for that question. It's very important to give assurance to the listeners, also on the future users of this technology. Again, the team, Rupam and team, has painstakingly validated this technology across various models of smartphones, and arrived at a situation where it needs a basic pixel specific camera. That's about it. It has to be a smartphone. And we have tested it against various user interface issues, like, you're shaking the finger, or, because it is a finger-based observation, or shaking your whole body and all those things. So there is an inbuilt indicator within the technology or the application. So when the user is not executing the test properly, it'll kind of highlight, saying that the test needs to be repeated.
That's great.
So
So
there is a
it
signal
picks up
quality report
errors
page.
and tells them.
Absolutely.
Okay. And I think the fact
So,
that if you see their product, it's ISO certified, and those third-party certifications really go a long way in the user and doctors also feeling comfortable that someone else has looked at it.
One other point what you have made is, in the first page of the report itself, it will give the quality of the signal.
Yeah.
So it will have a star rating. So if it has to be a minimum 3-star rating for you to proceed with sharing the report with your physician.
That's fantastic.
So otherwise, you need to repeat.
Even FetalLite has some features like that. I will, 1 second, I'll just get to you, Dr. Kadambi. Yeah, please go ahead. I want to wrap up. There's one more question.
I want to wrap up. That's why I said 2 minutes. But what I'm going to say is that in very, very simple terms, forget about what it does, how accuracy, because with time testing, all that will improve. The very fact that I can use this phone, put my finger here, just put a finger over here, and somebody in Timbuktu or wherever can take so many parameters using this technology in this phone to give you 40 to 50, 100, 200, 1,000 parameters. Itself is what I will say, this is a disruptive change, this concept of doing this. Now, how you use that application, there will be many. The other thing which aligns very well with what Kannan is doing is that you are no longer going to say that I am a diabetic, I have hypertension. It is not important. How is your cardiovascular system? How is your neuro system? How is your bone system? What is happening in your hematological system? So it will be a systems-based approach. A systems-based approach rather than disease-based approach, which is what we are all heading for, something which is called integrative or functional medicine, but that name is not important. We will be analyzing your cardiovascular system, your this system, and therefore, no longer we will be talking about diseases. The diseases classifications will have to change, and we'll have to look at various things. That's where the algorithm, the data, everything is going to be driven by algorithms and data, which is amazing. I just love the fact that with one finger, your finger can give you all that information. Isn't it amazing?
That's great.
Amazing.
So one question to Vibhav, and then Dr. Nilima had a point to say. So as a since you all are using FetalLite currently even in systems, are there other parameters that you need for a safe birth conduction, whether it be mother's blood pressure, so on and so forth? And are there plans to integrate either additional features or work with other IoT devices so you have a more comprehensive birthing room there? So please go ahead.
So right now we also detect maternal heart rate. So we are not taking BP yet. We can integrate BP. We also have an inbuilt partogram, so somebody can actually feed in the patient information if somebody is doing labor monitoring at home. Immediately we are not integrating anything else, but as and when we have a requirement, or a doctor or the hospital needs some additional input, we can integrate those easily because it's built to be modular. It's built so that multiple systems can interact and converse with it.
Okay. That's great. Thank you. Dr. Nilima, you had raised your hand. Did you want to comment on a particular aspect? Please go ahead.
I just wanted to say, having taken this test myself with the phone and the simple camera and the finger, it brings to mind as if it's like a back to the future. The old traditional methods of Nadi Shastra, where they used to feel your pulse with one fingertip and be able to tell all about your various systems and metabolism and immunity and everything with specific training almost intuitively. I think we are getting there back again.
Yeah, soon it'll be like the soap operas, right? Touch a pulse and know if someone's pregnant or not. I think Hindi films have predicted the future. So I think with this, it was a great session with good participation. I'll hand over to Dr. Vivek to have the last word and to close it out.
Yeah, the last word is also very simple. Last word is always thank you. But what is also in the great about Dr. Kannan's invention is that this is the finger, but you blow into the microphone, it analyzes your breath. It analyzes the force of your breath. So it's amazing that you blow into your microphone in a particular way. You're instructed, hold it here, blow it. So you are using the microphone to take in the data about these things. And I know IoT, I know my friend Vaidyanathan who's talking about the mic, your air around you, analysis of the air around you can be done with your cell phone. So look at the kind of information the cell phone can give you, the air around you, what's happening in your breath, what's happening on your fingers. And now, as I say, the future is here. All we have to do is application. So thank you very much. Thank you, guys.
Yes, thank you
have
all
a great
for
weekend.
your participation and great questions. And if you have any suggestions on future topics or future speakers, do reach out to us. Thank you. We'll see you.